Hello and welcome to today's presentation. In today's presentation, we are looking at renal transplant. Okay, renal transplant. This is one of the alternative treatments to dialysis in patients with renal failure. Okay, so let's go straight away and start defining what it is. Okay, great. Okay. Fine. So we are saying that transplantation is a surgical procedure to implant a healthy kidney from a living donor or a cadaver to a patient with kidney failure. We are saying that it is an alternative for patients who are otherwise having unmanageable end-stage renal disease, or which commonly result from either hypertension, diabetes mellitus, and glomerulonephritis. There is a possible simultaneous transplant of kidney and pancreas, more so to those patients with diabetes mellitus. You realize that patients with kidney disease are likely again to be having problems with diabetes, especially diabetes type 1. So there is always a possibility of doing simultaneous transplant of both the kidney and the pancreas. Okay, with such a dual organ transplantation suitable for patients with diabetes type 1 and end-stage renal disease. So what are the indications of kidney transplantation? Okay, we have three. Okay, number one, we have the kidney failure with the renal replacement, and number two, we have traumatic loss of kidney function will warrant transplantation, and number three, we have when there is a contraindication to dialysis. Remember, patients with kidney end-stage renal disease, the kidneys are no longer functioning, so they have to remove wastes through either dialysis, hemo or peritoneal. So if they are not able to do that, the only alternative is performing the transplant. Okay, so those are the three indications of kidney transplantation. What are the contraindications of kidney transplant? Well, we are saying that we have untreated current infection. The infection has to be treated before the transplantation can be done, because failure to do that, it can lead to rejection and infection of the very organ. Okay, active malignancy will also affect the new organ or the new kidney. Chronic illness with short illness expectancy. Is there a need for you to undergo transplantation if you are suffering from a chronic illness with short life expectancy? Yes? Let me get your views and see how it happens. But you're also saying that active substance abuse and reversible kidney failure can be one of the contraindication of kidney disease. So we have several contraindications. Others we have the relative contraindications. Okay, so relative contraindication, they are not as bad as the main contraindications, but they can also contribute to somebody not undergoing the transplant. So this one, they require careful evaluation and possible therapy before transplant. Okay, and they include active infection, coronary artery disease or heart failure, chronic liver disease, hepatitis, severe peripheral vascular disease, active peptic ulcer disease, cerebrovascular accident or disease, proven habitual medical non-adherence, or psychosocial barriers to post-transplant adherence, okay? Malnutrition, history of cancer, human deficiency, virus infection, primary oxalosis, and severe hyperparathyroidism are some of the relative contraindication to renal transplants. Okay, so how is the procedure performed? Yes. So in the procedure, you find that the surgeon typically leaves the recipient's kidney. The kidneys that are no longer functioning, the kidneys that are not functioning well, are not removed but are left there. Okay, remember these kidneys, even if they are not functioning to the maximum, they still secrete erythropoietin fluid, which is very vital for the person. So they can only be removed in chronically infected, okay, if they are chronically infected, or they are greatly enlarged, or they are cancerous, or they are causing intractable hypertension arising from no apparent reason, then we can have them. There is always also immediately before starting the procedure, the surgical team must take a timeout. They must verify, is this the correct patient? Yes. Is this the correct procedure? Yes. Has the site been marked with the undeniable ink? Yes. Correct. Usually the patient is normally given or receives general anesthesia. So the patient is going to sleep. So the surgeon makes a curvilinear incision in the right or left quadrant. So this one extends from the symphysis pubis to the anterior superior iliac spine and up to just below the thoracic cage. So there is a self-retaining retractor that is normally used to expose the iliac fossa, and a segmental separation, ligature, and division of the perivascular tissue is performed. So the surgeon then clamps the iliac vein and the iliac artery to prepare for anastomosis to the donor's kidney renal vein and renal artery. So remember, it is the iliac vessels of the recipients and the renal veins and arteries of the donor to be anastomosed, to be joined, guys. Okay? Yes. So in the meantime, the surgical team prepares the donor's kidney for transplantation. So if it's a cadaver is used, the team removes it from the cold storage or the perfusion preparation, and then it can be stored. Then it can be stored for 72 hours. But 72 hours, guys, although this can be stored in 72, we are saying that most transplants are performed within 48 hours. Okay, within 48 hours. So if the kidney is from a living donor, a separate surgical team normally removes it by either laparoscopy or laparoscopy assisted technique in an adjacent operating room and places it in a cold lactated Ringer's solution. So before transplantation, the surgeon will flush the renal artery of the donor kidney with cold heparinized lactated Ringer's solution, and this is just to prevent clotting and to remove residual preservative from the cadaver donor kidney. So the surgeon implants the kidney in the retroperitoneal area of the iliac fossa, where it is protected by the hip bone. Okay, remember, implantation in that iliac fossa is vital so that the hip bone can be able to protect these implanted kidneys. So if using a donor's left kidney, it's important that surgeon will implant it in the recipient's right side. Conversely, a donor's right kidney is implanted in the recipient's left side. Why is it so? Yes? We are saying that doing so allows the renal pelvis to rest anteriorly, okay, and enables the new kidney's ureter to rest in front of the iliac artery, where the ureter is more accessible, okay? Great, guys. So the surgeon will suture the donor's kidney renal vein to the recipient's iliac vein and the donor's renal artery to the recipient's internal iliac artery. So the surgical team then removes the venous and the arterial clamps and checks the vessels for patency. Thereafter, the surgeon attaches the donor's kidney's ureter, okay, to the recipient's bladder. Remember, the recipient's bladder has no problem, okay? So it's still intact, so it still has to be used. So this will have to be done ensuring a watertight closure, okay? So a tunnel technique is usually used to connect the ureter to the bladder to prevent urine reflux into the transplanted kidney. So when the plantation is complete, the surgeon sutures the incision and applies a sterile dressing. Okay? Okay, guys. So this is just but a summary of what we are looking at. Yeah, what we are trying to see. Yeah. We are saying that in the kidney transplantation, the surgeon implants the donated organ in the iliac fossa. Okay. The organ's vessels are then connected to the internal iliac vein and internal iliac artery. You can be able to see. There. Yes. Great. So typically the surgeon will leave the patient's own kidneys in place, that one we had said, and they are very important because they are going to continue secreting the erythropoietin fluid. Okay, so you are able to see, can you be able to see inferior vena cava? Yeah, is the one that we have branches of the internal iliac vein. You can see it is anastomosed there to the kidney. A transplanted kidney, it's here, you can be able to see. Common iliac artery, you can see. Okay, great, guys. So what are some of the complications of kidney transplant? So number one, we are saying you have rejection of the donated organ. It could be hyperacute, acute, or chronic. We'll also be looking at this in details so that you'll be able to describe it deeper, because this is the main type of complication. We also have others including vascular stenosis, leakage or thrombosis, ureteral leakage, fistula or obstruction, calculus formation, bladder neck contracture, graft rupture, cardiovascular complication, respiratory complication, cirrhosis, peptic ulcer disease, infection, the hematomas or the abscess, lymphocytes, corticosteroid-induced diabetes, hypertension, malignancy, liver disease, diabetes mellitus, and anemia. So what is this pre-treatment to this patient? We are saying that you need to prepare the patient for transplantation and a prolonged recovery period and offer ongoing emotional support. You encourage the patient to express feelings. If rejection is a concern, explain that if this occurs, it can't be reversed, okay? And dialysis will resume. And that the patient will have to wait for another suitable organ donor. You need also to reassure the patient that transplantation rejection is common and usually isn't that life-threatening, okay? Number three, you need to describe routine preoperative measures. such as physical examination, laboratory tests, X-rays, ECGs, bowel preparation, removal of hair from the operating area if ordered. So if the patient is on dialysis before surgery, you explain that dialysis will occur the day before surgery to clean the blood of unwanted fluid and electrolytes and ensure fluid and electrolyte balance is maintained. You need to review the transplant procedure with the patient and family according to their individual communication and learning needs. You need to explain what the patient can expect after awakening from anesthesia. Remember we said we are using general anesthesia. So this includes the presence of IV lines and an indwelling urinary catheter so that you describe the routine post-operative care. You need to prepare the patient for post-operative pain and explain that analgesics will be used. Instruct the patient in using a facility-approved pain scale. In most cases, you'll be getting the OPQRST, where you are able to rank the pain from 1 to 10, or the Socrates for that matter. You teach the patient, okay, the proper methods of performing coughing, turning, deep breathing, splinting of the incision, or if ordered, or incentive spirometry. The patient will have to splint as they cough, okay? As they cough, Great. You need to discuss the long-term immunosuppressant drugs that the patient is going to be taking and their possible side effects. Remind the patient that these drugs increase the risk of infection, so they have to practice their infection control measures. You need to instruct the patient and family members on the measures of infection control. You also need to begin giving immunosuppressants as ordered. Okay, you start giving them. Remember, the physician is going to prescribe several drugs and is required of you as a nurse to facilitate the administration of these drugs. Methylprednisolone, yes, most common among these. You need to administer blood transfusion as ordered. You need also to verify that the patient or the family member has assigned an informed consent form and that the signed form is in the patient's medical record. Remember, it is the role of the physician or the surgeon to get the consent from the patient. As a nurse, you have to ensure that the consent has been gotten through the best means possible. The diagnosis has been explained to the patient, the alternative medicine have been explained to the patient, and the patient has agreed voluntarily. If the procedure isn't an emergency, confirm the patient's nothing by mouth status. NPO. So this should be a minimum of 2 hours for clear fluids, a minimum of 6 hours for light meal, and a minimum of 8 hours for fried or fatty food or meat. Okay? Great. Verify that the patient has not taken any blood thinners. Could be aspirin, and other NSAIDs in the last week. Notify the surgeon if there is a history of bleeding disorders or if the patient is taking any anticoagulants, anti-inflammatories, aspirin for that matter, and other herbal supplements or vitamins that may affect blood clotting. Okay? So you conduct a pre-procedural verification to make sure that all relevant documentation, related information, and equipment is available and correctly identified to the patient identifiers. Perform a complete pre-operative assessment, noting any allergies. Obtain baseline vital signs. You verify that laboratory and imaging studies are complete as ordered and that results are in the patient's medical record. Remember, you need to notify the physician of any unexpected findings, okay? Administer preoperative medication as ordered, and then initiate IV therapy as ordered. In post-operative or post-treatment care, you need to assess cardiopulmonary and hemodynamic status closely, okay? 15 minutes, 5, 10, 15 minutes, 30 minutes, 45 minutes, hourly as you proceed, okay? And remember to report any abnormal findings. Maintain a continuous cardiac monitoring, okay? Why do you maintain the cardiac monitoring? You need to evaluate the wavelength, the waveforms for ECG changes, especially in hyperkalemia, guys, where we have peaked T waves, wide QRS, and prolonged PR intervals. If these occur, you need to notify the practitioner to administer to prescribe for you the calcium carbonate so that you can be able to administer as ordered. You need to monitor laboratory blood and urine test results closely. Monitor urine output at least hourly. Promptly report output of less than 100 mL per hour. Observe urinary catheter function and urine color, which may be slightly blood tinged for several days and then gradually become clear. Observe the incision site for the drainage of yellow fluid, okay? You know, yellow fluid which will indicate a urine leak, okay? If the patient is receiving mechanical ventilation, assist with extubating as soon as possible, usually within 6 hours. Administer supplemental oxygen as needed. Encourage coughing, deep breathing exercise, use of incentive spirometer after extubation, splinting and premedicating for pain as needed. You also need to screen for and assess patient's pain using the validated screen tools that you have talked about. You treat the patient's pain as needed and ordered using non-pharms, pharmacological, or a combination of these two approaches. Base the treatment plan on evidence-based practices and the patient's clinical condition, past medical history, and pain management goals. You need to monitor the patient's fluid and electrolyte balance. So you need to weigh the patient's daily and report weight gain, okay? Maintain nil per oral status until bowel sounds return. Remember, we have to auscultate for bowel sounds in all the 4 quadrants, and you need to listen for at least 5 minutes before you conclude that bowel sounds are absent. Administer histamine blockers to suppress gastric acid secretion. Begin a clear liquid fluid diet after the patient is extubated and bowel sounds are active, okay? So gradually resume to a full diet with restriction as ordered. Remember to institute appropriate infection control precautions. Use strict sterile technique when changing dressings and performing catheter care. Limit the patient's contact with staff, other patients, okay, visitors. Avoid exposure to people with an infection. Monitor the patient's white blood cell count and notify the physician of abnormal results. Also watch for the signs and symptoms of organ rejection, which can be hyperacute, as we had said, acute, or chronic, okay? Remember to report suspicious findings immediately. You need to change the patient's position, get the patient out of the bed to a chair within 24 hours, gradually increase activity as tolerated. You also need to ease emotional stress, okay? Allow family members to visit, okay? And you know when they are visiting, you take care of those infection prevention control measures, okay? So that, you know, the family is important because it's going to comfort the patient as much as you are doing, and therefore the patients will be able to heal better and faster. There's a warning, guys, and it's important to know that in a living donor transplant, Urine flows usually begins immediately after revascularization and connection of the ureter to the recipient's bladder. Once the connection is there, urine production starts immediately. But in a cadaver kidney transplant, anuria may persist for 2 days to 2 weeks. The patient will need dialysis during this period. Okay? So always allow the patients and the family to express their anxiety and fear and to discuss any concerns related to receiving the donated kidney. Remember, the patients may feel guilty related to the donor's pain or to the pain of the donor's loved ones or to the death of the stranger who made the donation possible, and such also needs to form part of your care as a nurse as you give holistic care to this patient. Remember, I had promised to look at the 3 major types of rejections, and here they are. And we are looking in terms of type of rejection, pathophysiological mechanisms, assessment findings, and treatment measures. So just to mention them, we have hyperacute, acute, and chronic. So what is the pathophysiological mechanism of hyperacute? In hyperacute, patient circulating antibodies attack the donor kidney several minutes to hours after transplantation. So what are the assessment findings? There is usually a severe drop in renal perfusion, and we have ischemia and death of the organ. What are the treatment measures for hyperacute? You need to immediately remove the organ, okay? Remove the organ, okay? Revert to dialysis as you wait for another appropriate organ donor, okay? Number 2, we have acute rejection. So the pathophysiological mechanism here, guys, is that antibody-antigen reaction normally produces an acute tubular necrosis that normally occurs within 1 week to 6 months. Okay? 1 week to 6 months. And this is normally after the transplantation of a living donor kidney. Okay? So what are the assessment findings? We're going to find symptoms or signs of infections, including fever. We could have rapid pulse, elevated leukocytes, and lethargy. We could have little or no urine. Okay? The patient could have hypertension. There is normally a weight gain of more than 1.4 kgs in 24 hours. There is kidney enlargement and tenderness, and we have elevated BNU levels and creatinine levels, okay? So the blood, urea, nitrogen, and creatinine levels are going to be elevated. What are the treatment options for acute kidney transplant rejection? We say you're going to increase the dosage of immunosuppressants. We're going to do dialysis if indicated, and we're going to remove removal of the organ if the functioning ceases. If the functioning ceases, we have no other ways than to remove the organ and resume dialysis. Lastly, we have chronic rejection, and here we have long-term antibody destruction of the organ. So this may occur from several months to a year after transplantation. The assessments will have rising BNU levels and creatinine levels, declining glomerular filtration rate, hypertension, proteinuria. The treatment measures, we have renal scan, renal biopsy, and other tests to determine the extent of the damage. We also have increased dosage of immunosuppressants, adjustment in diet and fluid regimen. We could do dialysis or another transplant if indicated. Okay, so these are the general types of rejection, okay, in kidney transplant. What's the patient teaching? We're saying that teaching should be family-centered. You need to be sure to include family or caregiver in the teaching when appropriate. Always advise the patient to monitor weight and take intake and output values, okay? You include specific parameters for notifying the nephrologist or the surgeon, okay? You need to teach the patient to check for the signs and symptoms of transplant infection or rejection, including the warmness, redness, tenderness, swelling over the kidney, fever exceeding 37.8 degrees Celsius, decreased urine output, weight gain of more than 1.4 kgs in 24 hours, and elevated blood pressure. Somebody has just asked me about weight in pounds and kgs. Yes, to convert pounds to kgs, we say 2.2 pounds will make 1 kg. Okay? 2.2 pounds will make 1 kg. Equally for temperature, to convert degrees Fahrenheit to degrees Celsius, we say that for you to convert 100 degrees Celsius to degrees centigrade, you have to subtract 100 minus 32. You get the answer, you take the answer, you divide by 1.8. You divide by 1.8, you'll be able to get the degrees Celsius. Equal converting degrees Celsius back to degrees Fahrenheit, you're going to take the answer, okay? You multiply it by 1.8, then you add 32 to the product. You have 100 degrees Fahrenheit. Very good, guys. So we're saying that you tell the patient that because of immunosuppressants that they are using, okay, to prevent rejection, the natural immune system has been compromised, so they have to know the ways in which they can try to avoid infection, e.g. washing their hands thoroughly, including before and after dressing changes and after coughing or sneezing for at least 20 seconds. You keep your hands away from the face and mouth to avoid getting infection to those opening, okay? Great. You stay away from people who have colds or other infections because they can easily infect you. You ask friends to visit only when they are well, and when they are around they can put on masks and practice some of the standard infection prevention to minimize the risk. Also, you throw used tissues in the trash immediately. Ask family members who have infections such as cold or flu to follow normal precautions such as using separate drinking glasses, covering the mouth when coughing, okay? Avoid working in soil for 6 months after surgery and wear gloves thereafter. You need to avoid taking care of pets. Okay, don't clean bag cages, fish or turtle tanks, cat litters. Make sure that the person changing the cat litter box covers it and takes it out of the home before changing it. Okay, to reduce those chances of infection. Great. You avoid receiving vaccines that consist of live viruses, such as live attenuated influenza vaccine, the Sabine oral polio, measles, mumps, German measles, yellow fever, and smallpox. Because the live virus may cause infections, okay? So before receiving a vaccination or before a family member receives a vaccination, you need to notify the transplant team and the practitioner for the instruction so that you are not infected. So take care of your teeth by brushing twice per day and seeing the dentist per year for cleaning, okay? You review prescribed medication dosages, frequency, duration of administration, rationales for use, expected results, and potential adverse effects. Stress the need for adherence to these drugs regimen, emphasizing that patients shouldn't abruptly stop these medications, okay? Yes. Stress the importance of a program of regular moderate exercise, beginning slowly and increasing gradually. Advise the patient to avoid excessive bending, heavy lifting, and contact sports for at least 3 months or until the surgeon permits such activities. Also, advise the patient to avoid activities and positions that will place pressure on the new kidney, okay, in the iliac fossa. For example, those long car trips, okay, lap style seat belts, okay, should be, the patient should be aware of. Remind the patient to wait for at least 6 weeks before resuming sexual relations. Alright, guys. Because pregnancy poses an added risk to the new kidney. Okay? So, if it's a female client, you need to provide a female patient with the information on birth control. Okay? Stress the importance of regular follow-up visits to the nephrologist or the transplant surgeon. Arrange for referral to home care and social services as appropriate for continued support and care, okay? Remind the patient to watch for fever. Rejection, guys. Watch for fever that continues for more than 2 days. Shortness of breath. A cough that produces a yellow or green substance. A dry cough that continues for more than 1 week. Prolonged nausea, vomiting, or diarrhea. An inability to take prescribed medication, a rash or other skin changes, vaginal discharge or itching, unusual weakness or lightheadedness, fluid retention or rapid weight gain of more than 1.4 kgs in 24 hours, pain or burning during urination, a decrease in urine output, blood in urine, strong odor to urine, and the urgent need to urinate or a need to urinate frequently. You need to instruct the patient to immediately report these findings as well as exposure to mumps, measles, chickenpox, or shingles. Okay? Thank you so much, guys. I only have one question for you, and it's about mycophenolate Mofetil. So the nurse is caring for a client being discharged following kidney transplant. The client is ordered Mofetil to prevent organ rejection, which nursing instruction is essential regarding medication use. Nurse A, you administer medication following breakfast daily. Nurse B, you need to contact the healthcare provider, the physician, at first signs of a rejection. You need to sprinkle the contents of the capsule on food. You need to administer the medication with an antacid to prevent stomach upset. 1 minute, guys, for that. What are we supposed to do when we are taking these medications that are likely to depress our immune system? Yes? Yes, signs and symptoms of early infection, okay? Yeah, so you're saying that Mofetil is an organ rejection medication that diminishes the body's ability to identify and eliminate pathogen. It's an immunosuppressant, guys. So identifying the signs and symptoms of an infection at an early site is helpful in treating the infection. The medication is normally administered on an empty stomach. Typically, capsule will not be open dispensing medication at one time. So antacids may decrease the absorption of the drug. Okay, so the gland needs to be taught and should be aware of the should be aware of those prevention measures. Okay, until next time guys, thank you so much. That wraps the end of our video. Kindly remember to like our video and subscribe in order to get more videos. Thank you so much and have a nice time.